Welcome everyone, Rush University Medical Center, Division of Nephrology, Renal Biopsy Conference for January 26, 2023. Today's CME activity code is 487535. If you're, we post these all on YouTube. If you're not subscribed to our channel, please do. And if you're not on our email list, send us a direct message and we'll be glad to get you there. Invite everyone, join our channel, and let's continue to grow this, what we feel to be a very valuable educational experience. Today's case is a case that I have with Dr. Schlottman. She'll be reading it shortly. As usual, we have nothing to disclose, and patient privacy is preserved as usual. I am going to start because last week, if you remember, I had a lot of technical problems with my audio. It was just a complete mess, and let's hope that doesn't happen again. But I want to make sure that I made my point properly, and there's been some additions to this since last week, which is the real reason I want to re-enter this a little bit. So if you remember, and then we'll get to the case after that, I just felt like it was interesting. There was some very interesting follow-up after last week that I wanted to include. So if you remember, I was kind of making the point last week that the PLA2R for membranous completely changed everything. It's the perfect GN biomarker. I don't know if we'll ever get one as good as that. It predicts the pathology. It's highly sensitive, highly specific, not 100%. Probably sensitive. I'm not so sure about specific for at least PLA2R membranous. The appearance precedes the onset of proteinuria, as you can see, and the disappearance precedes the proteinuria resolution. So it's a great marker of what's coming and what's going away. And it's important to realize that the proteinuria can take quite a while after the antibody goes away. And what's really useful is that the reappearance predicts relapse. Next slide. So I'd given you this list last week, and I actually added the protocadherin 7, which is the protocadherin FAT1, which is the membranous seen in human stem cell transplant. But what I tried to kind of give you an idea of, with all of these different antigens out there, that there are some things that kind of go together. First of all, the big three that first came out was PLA2R, thrombospondin, and NEL1. And then after that, there were these other ones. And that we'd gotten to the point where we had 12 when I was presenting yesterday. And here's some of the associations I thought of some value. So for instance, thrombospondin, we think about malignancy. NEL, we think about a lot of things actually. Semaphorin in pediatric patients, contactin-1 with CIDP, FAT1 and membranous associated with human stem cell transplant. Then there's some that we don't really have a correlation with yet, very uncommon, like protocadherin 6, serine protease, and netrin G1. Then the last three, I reorganized. These are the kind of the autoimmune ones. And certainly NCAM1 and TGF-beta receptor 3 have a pretty strong relationship to lupus membranous alone, whereas extosocin, also autoimmune, has association with lupus membranous, but a lot of other autoimmune diseases as well. It's also important to know that all of these that have been determined so far had a circulating antibody except the last two. And I think this is kind of where I thought we were in good shape when I left the conference last week. Next slide. But then, of course, by Saturday morning, Dr. Ruman had texted me this article that had just been pre-printed in Kidney International of 7 more antigens and that had been reported by the labs at Arcana. And you can see these the new antigens down on the left there. And what they found was, these are, again, minor antigens. They don't represent a lot of the missing part of the non-PLA2R membranous, but they're still out there, and these will probably be further identified as we go out. That at least when you look at lupus membranous on the far right here, 4 of them represent 12% of the membranous lupus, but they're not just lupus membranous down here. They're also, some of these overlap. For instance, MST1 and VASN2 is associated with lupus membranous and idiopathic membranous. So we're getting closer, but the closer we get, it seems like the farther we get. Since what was, like I mentioned, the biomarker. So now we had 12. Then we added these 7. So now we're up to 19. Next slide. And you can go on next slide. So what we know is that rituximab and cyclophosphamide work very well for PLA2R, and that as I mentioned, you treat, the antibody goes away, eventually the proteinuria goes away. Next slide. The question is, what happens with all these other antigens and antibodies to antigens that are also related? And we don't know that, but the whole premise of my talk last week was that if these are all antibodies, and if they're directed against some protein in the epithelial cell, that there's no reason, at least a priori, to believe that they would. But I would posit that they expected more likely than not, that they would respond. And so the real key here is that Dr. Glassick has always made the point of, precision medicine. We should use every tool that we have. And I totally agree with him. I think that we should use every tool we have to identify what we have, study everything we have so that we can be as precise as we can. The problem is that we've got this great system of PLA2R where we can measure it. And before we even start to look at some of the others, we've got 7 more. So now we're up to 19. And I don't know that we'll ever going to be able to have serum levels for the ones for which there's serum levels, which are the vast majority of them, and avoid biopsy like we can often do now with PLA2R because of sensitivity and specificity of it. I don't know if we'll ever get there. It's easy with PLA2R. I don't know about non-PLA2R, and I think it's going to only get worse and worse. But my point was, I do believe, in the absence of being able to tell exactly what you have, that would be the logical choice, is to go ahead and treat them as though they were idiopathic, now that we know the pathophysiology so well. Next slide. So just when we think we're done, Dr. Sethi, who, by the way, described the majority of these other antigens up until the last 7 that came from Arcana, just found the antigen that's associated with syphilis membranous. It's the DNDF, NDNF, thank you, antigen. And next slide. And then another tweet comes out a few days later from Dr. Kaza, who's at Arcana, finding that bucellamine is another drug that's associated with NEL1 membranous. And I think that's interesting. Bucellamine, it's used in rheumatoid arthritis. And now I'm really wondering whether or not, the early, I'm dating myself, but drug-related membranous that was associated with gold and penicillamine are probably both NEL1 associated, because of the association of metals to NEL1 and bucellamine associated with NEL1. I don't know that penicillamine has been, but I suspect it will be or is. Next slide. And so Dr. Sethi replies, to her comment about this being, bucellamine being N1. He goes, NEL1 is turning up everywhere, and refers him back to this patient, the many faces of NEL1 membranous. Next slide. And it's a really nice article, but basically he shows all the things it's associated with, including cancer, sarcoid, Sjogren's. And here's a really nice segmental one, which we've talked about before. And made this little diagram, and there's not much left here. You've got infections, you've got cancer, you've got transplant, you've got drugs. There's not much left with NEL1. So, you find NEL1, if you're able to stain for NEL1, you're still left with, this whole kind of big workup. And I don't know if that helps or hurts, but it just tells you how many lesions are associated with NEL1, unlike, for instance, contactin, which seems to be with, the neurologic disease, CIDP, or maybe syphilis is probably only that new antigen. Next slide. And so last week, I know I was making a long story short, or a short story long, sorry, but I tweeted after last week's conference. I spent 2 hours just preparing a talk on membranous antigens for a conference, to only find over the weekend from Dr. Rubin that 7 more came out. And next slide. And Dr. Sethi wrote back, well, here's my approach to the workup of antigens in membranous nephropathy. It's not perfect, but next slide. To start with the common, and I think this is a kind of a reasonable approach. I don't know that we'll ever get there, that we'll be able to stain all these, but it's kind of a reasonable approach to think about. So the common ones are PLR2 and NEL1, and despite the fact that thrombospondin was one of the early ones, it's really a very uncommon antigen. And then you could go to the disease-specific antigens, which was my original slide, which I had some things in red, exostocin and contactin, et cetera, associated with these. I'll point out there's yet another one here that's the non-steroidal induced associated under disease associated antigens. I was uneven aware of that till this diagram came out. I was unconvinced that non-steroidals even cause membranous, but this is probably a very good indicator that that's the case. And you work your way over to some of the less common antigens, and who will know where this all goes. Next slide. Oh, I'd like to point out that Dr. Sethi does follow me. Hit the next slide. Thank you. That took a lot of work, so I had to point that out. And now finally the common antigen. So he put out this other, I always like these. We have Dr. Lewis's original postcard from when he designed one of the early lupus classifications. And I think Dr. Corbett may still have that postcard. If not, we have a picture of it. But I like this. You know, this is what he actually sent out on Twitter, something he put on a napkin, I suppose, or a piece of paper. But basically, it starts again what he said, common, and then go to disease associated, then the less common, and work your way over. And we're still left with some unknown, which we don't know. And I suspect there'll be another 20 or 30 in there before it's all said and done. And I think with that, so I just wanted to, since there was so much that came up since then, I wanted to add that. And now I'll get to our case. Thanks for your attention. Kelly, you want to take over here?
Sure. Can you hear me?
Yes, we can.
Okay, perfect. Okay, so getting to our case, the patient is a 35-year-old Hispanic female with past medical history of anxiety and depression who was directly admitted for acute bilateral lower extremity swelling and nephrotic range proteinuria. 5 days prior to her current presentation, she had mild URI symptoms consisting of cough and rhinitis, for which she took a total of 800 milligrams of ibuprofen over 2 days. Her URI symptoms resolved after about 3 days. However, the day after her symptoms resolved, she noticed severe bilateral lower extremity edema to the point where her shoes did not fit. She was able to present to her PCP that same day, who performed blood and urine tests. Lab work was significant for a serum creatinine of 0.6 milligrams per deciliter and a serum albumin of 1.5 grams per deciliter. Her UA showed significant proteinuria and a urine microalbumin that was outside of the lab's reportable range. UA from 5 months prior was entirely normal. She was admitted the following day. Upon admission, she otherwise felt well. She denied any other over-the-counter medications or supplements besides the ibuprofen she took recently for her URI. She denied recent weight loss, loss in appetite, decreased energy, lymphadenopathy, night sweats, rash, or COVID vaccination. Her past medical history and surgical history were unremarkable, except for the anxiety and depression as mentioned above. Her social, in terms of her social history, she did not drink alcohol, use drugs, or tobacco. Her family history was insignificant for kidney disease, autoimmune disease, or cancers. She didn't have any allergies. Her medications included sertraline daily, 50 milligrams daily, an oral contraceptive, and an albuterol inhaler. In terms of her physical exam, her vitals were pretty normal. She was afebrile. Her blood pressure was normal at 110/70. Her heart rate was 84. She had a normal respiratory status and was saturating well on room air. She was 5'1" and 88 kilograms with a BMI of 34. She looked overall really well appearing. She had no periorbital edema. Her lungs were clear. Her cardiovascular exam was normal. She had no rashes, but she did have 2+ bilateral lower extremity edema. In regards to her labs, her CMP showed a sodium of 138, potassium of 3.8, chloride of 106, bicarb of 23, BUN of 8, creatinine of 0.58, glucose was 95, total protein was 5, albumin was 1.3, calcium was 10, total bilirubin was 0.6, alk phos was 70, AST and ALT were within normal limits. Her lipid panel showed a total cholesterol of 347, triglycerides at 213, HDL 67, and LDL of 237. Her CBC showed a white count of 8 with a normal differential, a hemoglobin of 15 with an MCV of 80, and platelets of 250. Her UA showed a specific gravity of 1.022 with a pH of 6.5, 600 protein, 1+ blood, 1 RBC, 2 WBCs, 15 hyaline casts, and 15 squamous cells. Her urine protein was 3,200 milligrams per deciliter. Urine creatinine was 320 milligrams per deciliter, and UPC was 10 grams per gram. Her hepatitis B surface antigen, hepatitis B core antibody, hepatitis C antibody, HIV antibody, RPR, ANA, ANCA, and anti-PLA2R were all negative. Hepatitis B surface antibody was positive. Her renal ultrasound showed normal sized kidneys with normal echogenicity and no hydro. A percutaneous renal biopsy was then performed.
Any questions for Dr. Schlackman? Great. Well, we're going to start with a poll then. So what do you think this patient's pattern of injury is? Notice we're no longer going to call it a diagnosis anymore. Is it, sorry, is it IgA nephropathy, focal segmental glomerular sclerosis, minimal change disease, membranous, or a post-infectious glomerulonephritis? I should probably just put in the future, I think I did this last week, just put MCD with FSGS and call it a podocytopathy, because I'm not really being true to my, pathophysiology, but we'll
Pretty
keep
good
those separate for
response.
now.
Yeah, pretty good response. We'll give it a couple more seconds here.
Yeah, nice response.
Nice. All right.
So we have nobody but IgA. I think I include that anybody with this ethnicity. And she had an upper respiratory tract infection, but yeah, no blood. So I think that would be pretty unusual. Focal sclerosis was 3%. Minimal change is the winner at 60%. Membranous at 30%, and a post-infectious at 8%. So I want to hand this over to Dr. Gashti. Can you tell us your thoughts about the case? What do you think we have here?
Yeah, so we have a young lady who essentially presents with, it seems like a rapid onset of nephrotic syndrome after she has this upper respiratory infection, which usually the timeline of how close the onset of symptoms were to the presentation of, with the upper URI and the urine findings, with a Hispanic young female. I'm just going down the list of your polls. IgA nephropathy on a test, like usually, first of all, she's very nephrotic and not very much hematuria, which is why nobody voted for IgA. And she had a UA from a while back that was completely normal. So I agree with everybody that IgA is probably at the bottom of the list. It sounds like minimal change disease based on how she's presenting. And whether this association with upper respiratory infection is sort of a causation, or she had this, and she was proteinuric and then she became ill because she was hypoalbuminemic. That's the other possibility. FSGS is also possible. Again, like you said, pattern of injury, maybe both of them podocyte patterns of injury after a viral infection. That's definitely been seen. All the hepatitis stuff, HIV, it's all negative. PLA2R is negative. So if this is membranous, it would be a PLA2R negative membranous in a young Hispanic. You think about lupus and some of these autoimmune diseases, but her ANA is also negative. So to have a secondary membranous with such a sudden onset, I feel like that's probably less likely. Post-infectious GN, her blood pressure is normal. She has a normal serum creatinine. It seems less to me like a GN and more of a nephrotic syndrome presentation to me. And with a normal blood pressure, I am also in agreement that minimal change is probably my top three.
Bill, what do you think?
Yeah, certainly. I think on the boards, explosive nephrosis equals minimal change disease. You have an absence of real hematuria. I don't think the little bit of blood that's there on dipstick with squamous epi's is anything. You've got classic nephrotic syndrome. If you have this clinical presentation, such as the sore throat and acute swelling in the absence of nephrotic syndrome, then my post-infectious and goes up a lot higher, because they can often come in very, very sodium avid despite the absence of nephrosis. But in this case, we have nephrotic syndrome. We don't really have to even think about that. And about the pattern of injury with focal sclerosis, I'd be comfortable calling this a diagnosis of primary FSGS if there is a focal sclerosis pattern of injury with foot process effacement. Her clinical presentation is consistent with a primary FSGS, and it's also consistent with minimal change. If she did have it, most likely would be a tip lesion, but any of those patterns, focal sclerosis can present with this presentation, even if it was the rare time of a perihilar variant could still occasionally present this way, which is kind of why we started calling it pattern of injury. But the
And,
primary
not only that,
FSGS
sorry, Bill, but that's exactly my point where I probably should have said a podocytopathy,
Sure.
and in parentheses, put minimal change in focal scores as opposed to separating those two in the poll.
And even if it is a membranous, I'd expect that we'd have diffuse foot process effacement. So I think the EM is going to really show a podocytopathy, but I think most likely this is going to be with normal light microscopy.
So Steve, Dr. Kark used to call minimal change asthma of the kidney because of the strong association with atopy. And I know that sometimes minimal change can be brought on by various immune stimulants like vaccinations, et cetera. Is it associated with colds, with upper respiratory tract infection?
Yeah, I mean, I thought sometimes it could be, that can precede it, the presentation. I know bee stings can do it, right? They've talked about that as well. But yeah, I thought it could.
So what's your diagnosis, Steve?
Well, I mean, everybody's already discussed the obvious ones. I'm going to say she has lupus with a podocytopathy.
Because?
Well, she's Hispanic, she's young, and this may be her initial presentation, latent lupus nephritis, if you will.
Mm-hmm. You want to just
the obvious ones you've got, everybody's already used up. I mean, I agree. I think minimal change disease has to be very high on the list. And an FSGS pattern of injury with a tip lesion, I think has to be up there as well. I mean, it could be an NOS lesion too, I guess. I doubt it would be a more proliferative lesion, if you will, like collapsing or the endocapillary lesion. But I just throw that out there in a relatively young woman who's Hispanic. I mean, generally, latent lupus nephritis is membranous, but I agree with the way this is kind of, as Casey has nicely pointed out, this is kind of exploded onto her, and I just think lupus podocytopathy, and then we'll see whether or not there's evidence of that, which would be immune complexes, tubular reticular structures, etc., on the biopsy.
So we use that term a lot, and I don't know that the audience is as familiar with this quote latent lupus concept that you and I and our group talks a lot about. Could you just elaborate on that a little bit?
Well, I mean, historically there were patients. I mean, it was generally with membranous who present without clinically, or serologically diagnostic lupus, who on biopsy have had features that were consistent with lupus, and then later down the line, years later, they would develop, overt lupus. The lesion most associated with that was membranous. Ron Falk and Charlie Jeanette did a nice job years ago differentiating, the histologic features of patients with latent lupus versus those with primary membranous, if you will. And I recall it included things like mesangial hypercellularity, subendothelial deposits, tubular reticular structures. If you had all three of those, the likelihood that you could have latent lupus nephritis, if you will, or that you may go on to develop lupus was very high. The negative predictive value, if any one of them were absent, then all bets were off. So you really had to have all the features present to have
really all of them.
Yeah, you couldn't have just one. You needed all three of them. And they looked at a number of features to determine the positive and negative predictive value. The negative predictive value is better than the positive predictive value, if I recall.
Yeah, I mean, but that was pretty much lupus membranous, right? It was pre-podocytopathy descriptions, correct?
Yep.
So, I mean, that kind of applies to class 5, but not this, podocytopathy,
Well, I mean,
which is
any lesion could do it.
No, that's true.
That was the most common.
Yeah. Yeah, and to be clear on that too, I mean, when we first described podocytopathy, it was a mesangial lesion with proteinuria, way out of proportion lesion with diffuse foot process effacement. But as Bill and others in our group have shown, that podocyte effacement can be seen in many lesions, and Bill's even posited in a recent editorial he wrote that this is independent lesion. It's an independent pathophysiology, that the podocytes may play a role. Very independently. It's not just one lesion, but podocytopathy could be a lesion on top of any of the classes. And of course, in the past, we would use things like if you saw membranous with, depending on the IgG subclass, or depending upon whether there's mesangial deposits, or like you said, tubular reticular structures, endothelial structures. You'd think that this was a secondary membranous that would kind of point you, more towards it not being what we used to call primary. But, now we're in the age of something else. And so, if somebody has exostocin or one of these other lupus-associated antigens, now that we're there, maybe that's the way to be thinking about this, that it's maybe latent lupus or something, or that lupus might show up, or this definitely is an autoimmune. Again, depending on how much splitting and lumping that you like. Dr.
That must-
Classic, what does this
Roger,
patient have?
Roger,
Yes,
can
Dick.
you hear me?
Yes.
There must be a miasma in Rush that introduces lupus to the diagnosis of every patient we see. I can understand that because lupus had its origins at Rush, lupus nephritis did. But in this case, the only thing in the clinical history that would even remotely suggest lupus is the gender or sex of the individual and the ethnicity. Nothing else suggests lupus.
Oh, I hope
And I want to comment, I think the use of the term podocytopathy as a clinical term should be discouraged. It is a pathological term, not a clinical term, and to use it clinically, I think is going to lead down the wrong path. That's just my own opinion.
Well, what would be a biopsy conference without you pointing out some misuse of pathology and description? So, point well taken. Steve, defend yourself.
I got nothing.
God bless both of you. Yeah, I think it's a good point because we are very. I have to look up miasma, so so I'll learn something from this. If not some pathophysiology, I have to look up miasma. It's apparently not having my own asthma. So, but you are right. We are very lupus centric, and we can't get away from that. A lot of that is the legacy of Dr. Lewis and Dr. Schwartz and Dr. Corbett. So. But I think that is a good point. It's hard for us not to think always of lupus. But so I think what we should do now.
I don't know. This miasma, I just looked it up. That's pretty harsh. It says a highly unpleasant or unhealthy smell or vapor.
Well, I'm glad I didn't look it up now, but you ruined the conference for me.
I think that sounds accurate.
Well, there's
I thought he was going. I thought he was going to say myopic.
Well, we are miasmically myopic. How's that? Once again, Dick, thanks for educating me. That was great. So I think let's do the wheel. Let's see what the path shows. Dr. Corbett.
All right. Well, I don't even have to read it. It's lupus podocytopathy.
Just don't be
process
miasmic.
defacement with electron-dense deposits in the mesangium and a full house.
All right, give me a second. I'm going to give you.
All right.
I'm going to give you the control. Give me a second here. All right, go ahead and click on the screen. Yep, you're controlling it.
God help me. All right. So here we have a low power trichrome. We've got 2 cores. I mean, at this low power, it actually looks pretty good. I don't see a lot of, and I don't know if we'll move on to the next one very quickly here, but I don't see a lot of scarring. I definitely don't see a lot of interstitial fibrosis or tubular atrophy. They actually look pretty good to me. David, are you there?
Yeah, I
All
agree
right.
with that, Steve. There weren't too many glands. You could just see one on that core on the right, near the top.
I see it right up in here.
Yeah,
But here's one over here on the left,
yeah.
maybe another one over here, but we'll get a higher power. So here we have the PAS and, it's kind of a medium power, I guess, if you will. What I can see here is there's some increased mesangial matrix. There seems to be a fair amount of activity out here in the parietal epithelium. I don't see any. Well, I don't know. I assume we'll have a better power, but some of these loops aren't open. I don't know if there's some collapse here, if you will. Other loops are nice and open, but there seems to be a fair amount of epithelial cell activity in certain areas here, maybe here. And again, mesangial increase in matrix more than hypercellularity. But I get the impression, at least in this area, there's some collapse. You want to bail me out here, David?
I think maybe overreading that a little bit. It might just be a funny cut of that area, but there
Well, like
wasn't
I said,
a
this looks pretty
collapsing
normal
scar
to
or
me.
anything there. Yeah.
So with the exception of the mesangial, mild to mesangial expansion, I guess it's otherwise normal. Here we have another PAS. In the tubules, it's kind of hard to say much about as an aside. I mean, I can see brush border, but the microtome must have been staggering here. Interestingly, the glomerulus doesn't get torn up, but the tubules do. The loops are open here. The mesangium, again, seems to be prominent to me. For sure, increase in matrix, and I think even in some areas you can see 3-4 cells, so increased cellularity.
Yeah.
Here's the vascular pole. I don't see as much prominence of the parietal epithelium in this one.
David, I have a question about the mesangial expansion. I remember Dr. Lewis used to say for a 20 or 30-year-old, that's a lot of mesangium. Is there mesangial expansion that's age-related?
Yeah. As you get to biopsy people in their 60s and 70s, there is some mesangial expansion. So this is abnormal for a 20-year-old.
Plus, I mean, at least in some areas, there's hypercellularity.
Yeah.
You agree, David, or not?
Yeah, I said I agree.
All right.
How does that mesangial hypercellularity or expansion narrow or expand your differential?
You asking me?
Yes.
Yeah.
It doesn't really. I mean, you can have minimal change disease with mesangial hypercellularity. That's a subgroup of patients, at least in the ISKDC, that took a little longer to respond to steroids, but they ultimately did. If it was widespread mesangial hypercellularity, if you will. I mean, you can see an IgA nephropathy, which people are pretty much discounted right now. You can see it in lupus. So I don't think it really changes much for me right now.
Steve, do you see any reactive podocytes on the previous one on the PAS?
Well, that's why I would say I didn't really see much here, like I did in the one before.
What about in the area of 2 o'clock, 3 o'clock?
Right here?
Yeah,
Not really.
okay.
Not like I would expect in somebody that had, a collapsing lesion, if you will. The previous one.
Somebody has a podocytopathy.
Well, that's okay. You can get this whole, in the EMs, we'll see if there's like microvillus transformation, things of that nature. But I thought this one had more activity, if you will, than the second one did that we saw. And then we've got.
Yeah. Steve?
Yes, sir.
Yeah, before you go on to the silver methenamine stain, could you go back to the last PAS? I'm surprised nobody commented about the structure at 5 o'clock, which consists of a lot of cells
here
surrounding a vascular structure, and I think that's the juxtaglomerular apparatus there. Maybe another cut would have shown the macula densa a little better, but that degree of cellularity in the juxtaglomerular apparatus is distinctly uncommon and suggests a hyperreninemic state.
Okay, good point. Yeah, I just said this.
Now,
was
this patient has not received any ACE inhibitors or renin-angiotensin system inhibitors before the biopsy, so you can't explain it on the basis of drug reaction. If this is true, and if this is hyperplasia of the juxtaglomerular apparatus, that is seen in minimal change disease because of volume depletion.
Okay.
That is not uncommon in acute onset minimal change disease, and I'll reckon back to the hemoglobin concentration of 15 grams per deciliter in this young woman with perfectly normal renal function.
Okay.
I think this is pathologic, but I really would like to hear the pathologist's view on this.
David, you think that's too much cellularity there, or is it just the perfect cut through the JGA?
I think,
Any bets on what David's gonna say? Should we take a poll?
yeah. Having seen the entire case, I didn't think there was anything pathologic here.
Okay, all right.
It's still an interesting point. I'd never heard that before. It's an interesting point.
Yeah, I was gonna say, the other thing, too, the patient, I mean, it may be because of hypovolemia, because the patient's definitely not
Well,
hypertensive.
we don't often get such a good cut
Yeah.
right at the vascular pole, which is
Yeah.
this case. Most of the glomeruli we see in the biopsy are like the other one, the first one, which is not a cross cut across the vascular pole. Well,
No,
okay, so this is non-pathologic, but clearly something that you don't see very often, I think.
yeah, we don't really see the vascular pole here, as you
Okay.
pointed out before. Let's go on. Well, I guess they used up all the silver in this silver stain. Again, the mesangium's pretty prominent. I definitely don't see any splitting. At this power, I don't see any holes. I don't see any spikes. That doesn't mean the person couldn't have membranous, even though we put that, I think, fairly low on the list, because the fluorescence will be more helpful. But other than this is a pretty intense stain, I don't really see anything here that helps me. David?
Yeah, I agree with you, Steve.
All right. Well, the IgG, I would say, is negative. I mean,
Look up at 12 o'clock, Steve.
Look at the dusting.
Well, okay, I'm sorry. Yes, I see there's granular deposits right here.
Yeah.
It just seems so faint when I first looked at it, but here are granular deposits here. You can see them here, here.
Yeah, they were segmental because more than half the glomerulus was negative, but there are some areas of positivity. We'll see that area at a higher
Yeah, we
power
get back
next.
to this
Where are they?
right up in here.
No, I mean, are they on the surface of the podocyte or are they on the basement membrane?
These look like they're in the capillary wall.
Yeah, there's a basement membrane
And,
deposit.
I mean, we'll see on the EM for
Oh.
sure, but they look like they're on the capillary wall. Same thing here.
Well, that one, yes, but where, just,
Yeah,
boy.
you're right. No, I trust me, I had a hard time seeing.
Yeah,
it.
go to the next slide because I put that area under oil, so you'll have 100 times magnification. There you go.
Okay.
well,
So you
show
see-
us the basement membrane now. Is that basement membrane there or is that a
Yeah,
podocyte?
Well, this is basement membrane right here.
Yes,
Here it is here. Here it is here. Now, this looks almost like mesangium.
Yeah,
Here's basement membrane here, and you can see it.
and then
Here-
to the,
here-
yeah, there you go.
Here we see it again.
Yep.
Right in here. I assume that that's what this is too. It may be an
Yeah.
en-face cut, but
Yeah,
the
that's what I
EMs are
thought
gonna,
also.
the EMs are gonna be,
Mm.
I think, where we're gonna get a little more help. So this gets back into this whole patchy staining that was discussed, I think, sometime in the past already as to which antigen it could be. Now, my recollection was, and remind me again, Roger and Kelly, the PLA2R was negative.
Yes, it was.
Yeah.
Oh my
Yeah,
God,
it was negative in the
Yeah.
tissue also.
those podocytes are
I-
great. My God.
Hmm.
So, yeah, the podocytes here are look pretty good, actually. Here too. Here, there might be some, there's some focal effacement. Here it looks pretty good. There's again, some focal effacement. Same thing here, but it doesn't look, it doesn't look like, especially this loop, doesn't look like it's 80% or more. It's kind of a low power and I'm sure they're higher, but I honestly have right now at this power, there may be some deposits here. But hopefully there's a higher magnification. Yes, David?
Well, yeah, we'll see higher magnifications, but I didn't see any clear deposits on EM.
Well,
Ah,
you're taking it away from me here. I was supposed to
Ah.
describe that.
Okay.
the plot thickens. No subepithelial deposits by EM.
Yeah, remember though, look at the IF. I mean, it was very segmental.
Well, so here we look at it again. You're right, Dick. I mean, I don't see a thing. Basement membranes actually look thin. but I'm sure you've measured them, David, at some point. And
Yeah, I
there's-
measured them and they're within normal limits.
Now
And
here
there are some areas of thinning there.
here's more diffusely effaced. Here looks more diffusely effaced as well. Obviously, I assume it's a red cell.
Yeah.
I don't see any really good deposits. Here's another one. The foot process is, fairly effaced here. I don't know if there's some kind of artifact here with the fixation. But I mean, I don't know what this looks kind of funny in here, but this is the, the capillary lumen, this is the urinary space.
Hyperuricemia.
Okay. But I don't see subendothelial deposits. I don't see any of the subepithelial deposits. There's no mesangial deposits, and there's more widespread effacement than I recognized on at least the first one.
If you go back to that mesangial area, there is a little density in there.
Right there,
Yeah, right there and down to the right a little bit where the base of the arrow is.
right in here.
Yeah, right in there. Yeah.
Jesus God, I gotta get my eyes fixed.
Yeah.
Get better glasses. But I mean, yeah, okay. So there are very, very few deposits, but there are
Yeah.
some deposits there. I don't know what to make of that.
And no TRIs, no subendothelial deposits.
Huh.
Well, we got a pattern of injury here.
Yeah.
We've got
Well,
mesangial
is this a lupus photocytopathy?
No, I don't think so, Dick. I think you were right
Okay.
on target
All
there.
right.
What is it, Steve?
Well, I mean, I can describe what we saw, and that is, we saw basically mesangial hypercellularity. Was that more widespread, or was that just unique to to that one glom?
That was unique to that one glom.
Man, I mean, for lack of any other, it's kind of hard to call this membranous with just those very few deposits. But
Yeah.
it's somewhere between, it's either a very early membranous that isn't very widespread, or this is minimal change disease, or a pattern of minimal change disease.
But there was, yeah, again, the foot process effacement was not diffuse. It was 30 to 40%.
Well, yeah, man.
And in the chat, they're talking about this dusting. Is that consistent with the dusting?
I mean, this whole thing with the IgG, I think we were talking about this a few weeks ago. This whole issue was it NEL1 that can be patchy. And I don't know if you've sent this off to have it evaluated for some of these other antigens in membranous, but
Well, I think the antigen that I would be looking at would be nephrin.
yeah, but I mean, with only partial focal foot process effacement,
It doesn't bother me.
doesn't bother you, okay? All right. Like, we don't need no stinking badges around
Exactly.
here.
We don't need no stinking diffuse foot process
Yeah.
effacement.
Well, I think the problem is that you're doing this just by an inspection. What you need to do is morphometry and really look at the slit pore dimensions, which
Yeah.
can be done by morphometry. And my guess is if you did morphometry on this, that this is a lot more effacement than you think.
Yeah, I mean,
That's just my guess. And I think that stuff there is dusting. I would work this patient up for an antinephrin disease.
yeah, so you're left with a minimal change disease pattern, I guess, for lack of a better way of explaining it. And then just making sure that there's nothing secondary. I mean, she wasn't on any medications. It doesn't sound like she has lymphoma. And then the question is, does she have an anti-nephrin antibody? I can't disagree with that evaluation at all.
How often does anti-nephrin antibody show up on a standard immunofluorescence IgG stain?
Pardon?
So how often does anti-nephrin antibody show up on a standard IgG immunofluorescence stain? If it showed up, we would have seen it. This is not, you need special anti-nephrin antibodies to demonstrate that, no?
Well, I assume you have to find them in the serum, right?
Sure, right. But the
But if that were the
nephrin,
case,
the
minimal change,
anti-nephrin,
if that were the case, minimal change wouldn't be minimal change. It would have some deposits.
Well, that's the whole problem with the description of the nephrin dusting and the anti-nephrin antibodies. Is it really minimal change? And how many of pure minimal change are really anti-nephrin? I mean, it's really only seen in the ones with dusting, and people think, I mean, Beck was on the paper too, and they think maybe this really is a minimal change. I mean, Ranke called it that still, but so there's clearly either, a new anti-nephrin kind of disease that mimics minimal change but has a little dusting, and then that does take it out. But remember, mesangial deposits or mesangial hypercellularity can be in minimal change too.
But he said it wasn't widespread. So, if you only have a few areas, then you have to have widespread. I mean, yes, it can be, but it can be, but to call it mesangial, mesangial hypercellularity in minimal change usually was more than 50% was my recollection in the ISKDC where they categorized it at that. But, and David's saying that this was more focal than diffuse, if you will.
So Bill, you cleared that up for me. Thank you.
So I'm at a loss. David, what'd you call it? We'll go to the pathologist.
Early membranous nephropathy, I can't ignore those deposits were real on the immunofluorescence. And, Mel Schwartz used to say, nobody knows exactly how long it takes for deposits to show up on the EM. We not uncommonly see a positive immunofluorescence, and then there's no subepithelial deposits on the EM, and we still call those membranous nephropathy.
It does make sense though, if if you go back to one of the IF, and if the EM is only looking at one capillary loop of that IF, and that part is not where the deposits are, then of course there won't be deposits. So I don't think it's
no, but it is interesting. You've got somebody here who's got 10 grams of protein, for goodness sakes.
Sure.
I mean, and again, it correlates more to the
I think the more shocking
process of effacement, but even then he's saying, of course, it may be a function of not looking at the slit diaphragms closely enough, but at least crudely, he's got focal effacement. I mean, a lot of things aren't fitting together as nicely as we'd like, and I'm hoping Dr. Rodby, since he's presenting this, has some answers for us.
So David, to what you mentioned, it implies that early on in membranous, the electron density is such that it looks kind of like basement membrane, so you're not picking it up, but with fluorescent, you're picking it up. And then later on, the color changes or the electron density changes, so it comes up on EM.
That's right. Yeah, the EM deposits are latent to show that the fluorescence finding is first and early.
Well, so now we have latent primary membranous.
Well, we're going to move on because we have some more things to do. And but Steve asked me for the answer. I don't know the answer. I looked at this, quite frankly, as membranous, and it was so segmental that the EM might not have. If you don't see the areas where the deposits are, you may just be negative. And maybe I'm being a little simple, but that's the way I looked at it. I didn't look at it as quite as extensively as you guys did. We have a poll now. Based on everything we have here, we've got a wide differential, a membranous differential to a minimal change and everything. And so I would ask, how would you treat this patient with a CNI, rituximab, ACE-ARB, SGLT2, a cyclophosphamide-based protocol, or steroids? I put this wonderful picture of Steve and Dr. Schwartz in the chat. I hope it came through. It shows on my screen. It's so great to see Mel. We miss him so much.
So a good discussion here with the poll, as people will see. Keep on having your votes come in.
Various people have asked about the immunoglobulin. It was not isotyped or subtyped, so we don't really know. We have what we have today.
Okay. I'll end the poll there. We'll be able to see the results.
Well, by one vote, rituximab wins over steroids. And we have a little bit of ACE and ARB. I assume that means watch, and one cyclophosphamide, and nobody uses CNI, thankfully. Always glad to see CNI lose. Next slide.
I can give you control here. Give me a second. Go for it. Click on the screen. Yep.
So let me just ask really quickly. Casey, what would you do?
I mean, if you give Rituxan, it covers the membranous and it should cover the minimal change disease. I mean, I'm not completely against CNIs. I mean, at least voclosporin, there's some data for lupus nephritis, but because of the lack of foot process effacement, I'm not really sure if the steroids are going to be effective. I'm going to go with Rituxan.
Dick, what would you do?
What?
What would you treat him with, Dick?
Oh, steroids.
Steroids.
I think steroids not only just therapeutic, but diagnostic as well. If the patient had a complete remission within 2 weeks of steroids, this isn't membranous. So I would give steroids. I think it's safe and you'll have an answer fairly quickly. And obviously, I'm more biased towards minimal change disease in this particular patient.
Bill, just an answer, no explanation.
Stop the NSAIDs. But I would also, I would pick Rituxan.
Steve, one word.
I would start him on prednisone, start her on prednisone, and then try and give her Rituxan. I wouldn't wait for the Rituxan because God only knows unless you're going to give it right in the hospital. But
that was not one word. So Rituxan. Okay. So patient follow-up, we did the biopsy. Patient was discharged awaiting the path. She went on home on a low sodium diet, did not require diuretics. In fact, her edema got significantly better. And I just assumed that was because of her watching her diet so well. Pathology is available. We weren't able to get thrombospondin, exostocin. We can get them because we sent it to Mayo, but Mayo doesn't do NEL1. Arcana does do NEL1. I've been informed now that Mayo will do NEL1. So I think that going forward, we'll be able to at least get some of these more common, not maybe minor, but more common antigens. Well, thrombospondin is not common, but more available. Malignancy workup was initiated. I anticoagulated her. I referred to rheumatology for rituximab. Part of the labs was to repeat her protein, and it was still elevated. I might have lost my ability to click here. If you could advance. Okay, thank you. And this is what happened. So she sees rheumatology, and she tells me again, oh, my edema is completely gone. My urine's no longer foamy. And I repeated her, this is 2 weeks later, waiting for approval for rituximab, and her proteinuria went down from 10 grams to 1.4 grams. Her albumin came up to 2.6. I didn't believe it, or it was too hard to believe, although the albumin did come up. And I repeated another week later, and she's down to 0.7 grams per gram. So whatever she's had a spontaneous remission. Next slide. And if you remember, just not that long ago, Dr. Whittier had this almost identical case. He was because it was a second opinion, he was able to get NEL staining, and it was NEL1 positive, who also went into a spontaneous remission very rapidly, and very much looks like our case. And so, in my mind, I think there's a good possibility this was NEL1 membranous because it was segmental. And that, perhaps maybe this was a spontaneous remission. Remember Bill's case? Bill's patient had gone to the Philippines, and maybe we'd suppose that maybe she had taken something there, although Bill could never figure it out. But the list of what people take that are causing NEL, which remember, Sethi's the many faces of NEL. We've got lipoic acid, we've got, metals and everything else. I'm beginning to wonder if that wasn't the case. I asked her, she couldn't give me anything that she'd taken, but I don't know. It's hard for me to believe that you can have such an acute onset that could get better so quickly. Honestly, I think her edema was getting better in front of us. And I think if we would have waited, a week or two to get the biopsy done, her proteinuria would have gone away. We would never known, and we'd never biopsied her.
She was on NSAIDs though.
What's that?
She was on NSAIDs.
She was on NSAIDs, but this isn't really that. In my mind, that's not the picture, but okay. I mean, maybe an NSAID induced,
Well, the other
minimal
question
change.
is maybe this was some viral issue. I mean, I don't know. You said she had a URI the week before or something? Or a few
Yeah,
weeks
she
before?
did. She had a.
You start to wonder whether granted, there was no segmental, but parvovirus or something that I don't know how many gloms there were on the biopsy, but it is kind of interesting that it spontaneously improved so quickly.
So if I would have put her on steroids, I would have said this is, she had minimal change and she rapidly responded. It was only because it takes 2 or 3 weeks to get, rituximab approved that we actually realized it was a spontaneous remission. So I went back and looked at, the clinical spectrum of segmental membranous. This is from Glenn Markowitz from Columbia. And over the 2010 to 2018, they had 50 cases of segmental membranous, but only 29 were pure membranous. Some of them had other things going on. So they looked at those. The creatinine was pretty normal at 1. The urine protein was not that high, and only 32% had nephrotic syndrome. Now remember, our creatinine was fine, but this patient had 10 grams, was clearly nephrotic. back then they were able to stain for this, and all patients were PLA2R, thrombospondin, and exostosin negative. It'd be curious to go back and see if these were NEL, how many were, well, no, they did look at NEL, I'm sorry. They did NEL staining at that time, and they found that, because this was only 2020, yeah, NEL staining was done in 17, only 5 of which were positive. So it's not like all segmental membranous is going to be NEL positive. So it may be one of these other antigens, but it's the one that we at least identify being NEL positive. And follow-up, I mean, the important thing is follow-up is patients do pretty well. 86% got better, 45 complete, and 15 in partial remission. Next slide. And I stole this from Steve. This is Steve's slide on spontaneous remission of nephrotic syndrome. This is much, much older, before we knew all about all these antigens. But this was by Dr. Polanco, and he had looked at 328 patients of membranous that were treated conservatively. So you had to kind of assume it was a spontaneous remission. That's a lot of conservative patients. And I suppose it's a little biased already, because if you're going to treat somebody conservatively, it's not going to be as severe a nephrotic syndrome, I would think. Even Doki back then was not recommending conservative for severe nephrotic syndrome. But 104 had a spontaneous remission. That's a total complete and partial remission. But if you look at across the 3 proteinurias, it really was pretty equal, about 14 to 17% at a complete remission, and a little bit at a partial remission. So if you add those together, you end up with 32% had a remission. So at least spontaneous remission does occur, probably in our less severe patients. And only 6 relapsed out of that number that had that, which is, I think, is pretty remarkable. Next slide is also Steve's. It was pretty interesting that they found that the patients that were on ACEs and ARBs were much higher incidence of spontaneous remission, which I can't really explain. I mean, we always think that it reduces proteinuria, but I don't know why that would affect actually developing it, unless it's just masking it somehow, and they never really stopped it to know that the proteinuria went down. Steve, do you have a thought about that?
No, I mean, it may have been that the patients that were less nephrotic were more likely to respond to ACE and ARBs than the ones that were more nephrotic. But the thing is about this, in the first slide, this is over a several year period of time. This isn't like over 5 months or 6 months. Okay, over 15 months, yeah. So there's a 32 over a mean of 15 months. So and then the next slide shows you. So it's not over a couple of weeks, I guess, is my only point.
Yeah, Steve, I'm really glad you said that, because that's a point that I've kind of left out, which I think is extremely important here. It's not something that's a couple of weeks. Yeah, it's a slow. I mean, some of these were early, but most of them took quite a while before you saw that. I think that's a really good point. Thanks.
I mean, the difference between this study and the one that Schiapetti did years ago, which Ed actually wrote an editorial on, was that these patients were all nephrotic. In the other study from Italy, the Schiapetti article, a lot of those patients were not nephrotic to begin with. So that kind of clouded the whole thing. The beauty of this one was they were all, at least had nephrotic range proteinuria.
May I point out that Dr. Cameron, when he did his review, the natural history of this entity, pointed out that 1/3 of them will have a spontaneous remission. So way before Dr. Polanco published in JASN.
Yes, that's interesting. I remember as a fellow learning 1/3 of them are nephrotic.
You
A
weren't
third of them have
born.
proteinuria without, and a third of them get to develop, progress. 1/3 of them stay the same, and 1/3 of them get better. But I never saw the data from that. So that's the paper you're referring to, Mario?
I don't think that you and I were in medical school when Cameron did this.
Oh no, yeah. You're not that young. I even remember seeing that in one of the reviews, and it was a similar kind of figure like this.
The famous rule of thirds. Thirds
Yeah.
get the same, third get better, and a third get worse.
But
Yeah,
what's
exactly.
great
And
about it
there's
is
nothing like rules that are equal like that help you remember things. So I'm glad you brought that up. Yeah.
Even minimal change. Black showed I think it was in I forget which, if it was the Lancet or British Medical Journal. Black years ago showed that, if you didn't treat if you didn't treat patients with minimal change disease over the course of a couple of years, a significant portion of those would go into a remission spontaneously. But if you gave them 30 milligrams of prednisone, they would go into remission quite quickly. So, a number of these things can go into remission spontaneously. It just usually takes a lot longer. That's why I think whatever's going on in this patient makes you wonder whether there was something there that's not there anymore, whether it was an NSAID or a virus or, who knows, maybe it was
And maybe all of the spontaneous remissions were really that from the get-go, they were taking lipoic acid, or they were taking, some medicine that was inducing it. And now as we're learning more about those that have antigens and so on, maybe we'll be able to target who's more likely to have spontaneous remission in the future. I think that's the great exciting part about how membranous keeps changing based on new data.
That's a really good point, Bill. I mean, if it's an exogenous antigen that you're taking, that could be finite, gold or lipoic acid. But if it's an endogenous antigen for some neuroantigen from a neurologic disease, et cetera, or bone marrow transplant, that might not necessarily go away. That's a whole nother story. Yeah, that's a really good point. It's
Right.
very exciting. I'm going to wrap this up with my last slide.
Well,
Yes, Dick, please.
well, I don't think we should leave this subject that is sort of leaving us with the impression that she had some unknown antigen causing segmental membranous, maybe at NEL1, without saying what was the subclass of IgG deposited in this case. If it's not IgG1, it isn't likely to be NEL1. So I think we have a lot of missing information in this patient to draw firm conclusions about the diagnosis, in my opinion.
I agree. And I think that once Mayo is able to supply us, since that's where we have our contract with, and we can't just go sending anything anywhere. Once they're able to supply NEL1, I think that we'll send this case back and give them the paraffin block and see if they can further let us know. Because no, you're right. I mean, I don't know. I like the story, but I like stories, but it doesn't mean that it's the right story. I like Bill's story. I like my story. I think we've got the same case, but who knows? Who knows? We know Bill's was Nell. We don't know what this is. Is this dusting, or is it really a membranous that we didn't see the deposits because of sampling error? I don't really know, but I think it's kind of a remarkable case, and
Right.
I didn't even realize until Praveer and I were talking how similar this was. I tweeted out, by the way, is to sell people on this case. I said, is this a wolf in sheep's clothing, a sheep in wolf's clothing, a wolf in wolf's clothing, or a sheep in sheep's clothing? And basically, somebody nailed it. And when they wrote back in the chat, this was really a wolf in sheep's clothing. It looked like something bad that went away on its own. So I'm glad somebody caught on to that and answered it for me. And the last slide. Since Dr. Sethi is the hero of all this and has discovered so many of these antigens, I thought I'd put this picture up. This is from ASN Kidney Week this year at the GlomCon party, and he was what a gentleman. He was so nice to take a picture with Bill, Praveer, and myself. And so, cheers to him, and congratulations on changing the face of membranous glomerulonephritis. So, thanks everybody, and we will be off next week.
Thank
I'll
you,
be
Roger.
sunning in beautiful Caribbean, but we'll be back shortly after that. So everybody stay safe.
Thanks, Roger.